Good morning, everyone. As folks are getting on line, we'll give everyone a minute to join the webinar. Welcome to today's webinar in our OUD in the Emergency Department series. So today's webinar is all the technical detail you need to know: dosing, risk, readiness, and other technical questions. For this webinar, we have a couple housekeeping items here. All participants will be muted. Any questions that you need to ask, feel free to ask them in the chat at any time or in the Q&A area. If you're unable to use those features, feel free to send me an email at samantha.lasky@iphionline.org, and I'll look through them there. And then we will have a Q&A at the end with our subject matter experts. Please stay for that, as well as to learn more about evaluation and CME approval. So with that, I will pass it to Alyssa Bassler, CEO at IPHI.
Great. Thank you, Samantha, and thank you everyone for joining. We're very excited to have this third in our webinar series. Our project is working with Chicago emergency departments to increase their capacity to respond to the opioid crisis. It's funded by the Chicago Department of Public Health via a Centers for Disease Control and Prevention grant that they have. And the work is really to focus on helping emergency departments strengthen their ability to dispense naloxone to patients who are at risk of overdose, to initiate buprenorphine or other medication-assisted treatment in the emergency department, and make referrals to community providers for ongoing treatment. That's something that we worked on a couple of years ago to make sure that that was Medicaid reimbursable, and Dr. Batari will talk a little bit about that and a little bit later in the presentation, and also to connect those with opioid use disorder to immediate medication-assisted treatment through the MAR Now project if you're not referring them to some other community provider. Next slide, please. For this webinar today, our objectives are to discuss how to assess a patient and determine the appropriate dosage for buprenorphine initiation, to describe common dosing questions such as how to treat pain in opioid-dependent patients, and to review where to get real-time information for clinical questions arising in the emergency department related to buprenorphine initiation. Next slide. We're able and happy to be able to offer continuing medical education units via the University of Illinois College of Medicine. And there'll be some information and evaluation and so on at the end of the webinar so that you can acquire those CMEs. Next. The program itself, the webinar series, is four webinars we've done. Today is our third one. We did one in June on what the emerging standard of care is for opioid use disorder in emergency departments. A couple of weeks ago, we did a fantastic presentation with Dr. Richardson on overcoming stigma and bias in opioid treatment. It's a huge barrier to people getting treated and saving lives. And then today we have Dr. Batari to talk about the technical detail for dosing, risk, readiness, and other technical questions for emergency department initiation of buprenorphine. Next slide, please. And our presenters and subject matter experts and partners through all of this work for several years have been Dr. Jessica Richardson, who's a family medicine and addiction medicine doctor at Near North Health, Dr. Steve Holtzford, who's a ED physician and leader in addiction medicine, and our main presenter today, Dr. Diana Batari, who's the medical director for Controlled Substance Monitoring Team at Advocate Aurora Health. And they'll do a little more to introduce themselves as they talk. So I think now I'm supposed to hand it over to Dr. Batari.
Yes, and I'm very happy to be joined by my two favorite subject matter experts, Dr. Richardson and Dr. Holtzford. Dr. Richardson, do you want to introduce yourself?
Yeah, of course. I think my camera's gonna, hi everyone, I'm Jess Richardson. I am a family medicine, addiction medicine doc here in Chicago, on the west side of Chicago. I was born and raised in Chicago, and The substance use disorder patient population, especially for minoritized patients, is extremely near and dear to my heart. And I am very, very proud to be a part of the IPHI team. I'm going to flip it over to Dr. Holtzford.
Hi, thanks, Jess. Steve Holtzford. I am a ER doctor for many years. And 5 or 6 years ago, I started to become interested in addiction medicine. And now I'm just really love addiction medicine, love the patients, love that they get better. And so I have not done an ER shift in almost 2 years now, but I'm still passionate about the treatment of patients struggling with substance use disorder within the emergency department. Thanks.
Thank you. And I'm Dr. Diana Vitari. I am the medical director for Controlled Substance Monitoring Team. Clinically, I am an addiction medicine specialist as well as pain management. And so I'm really excited to be a part of the IPHI family to be able to help with this webinar series. So, it's really important we kind of just go through this. And I know that some of you guys have attended our other 2 webinars, which is fabulous. But we do want to kind of just gloss over what the opioid crisis is currently. Okay, so in 2021, 108,000 people died of an overdose, and 80,000 of those deaths were related to opioids. To kind of put that in perspective, in 2016, when we started hearing more and more about the opioid crisis, we were talking about 42,000 deaths. Okay, so this is a huge increase, a huge uptick. Now, specifically in Illinois, we saw 3,600 people die of an opioid-related overdose in 2021. Now, to put that in perspective on other deaths, this is almost 4 times the homicide rate in Chicago. Now, we are all over the news in the city for the city of Chicago for homicide rate. This is 4 times the homicide rate. And it also represents 2.5 times the number of fatal car accidents in that same year. So if all of a sudden 2.5 times people were dying in fatal car accidents in the state of Illinois, what would happen? What would change, right? We would be demanding from the car industry, you have to change things, right? We'd be looking at all of the reasons why this is happening. But you really don't see that same kind of push when it comes to opioid overdoses. Now, what are people overdosing on? And a lot of you guys on this call are going to know that it's fentanyl, right? But did you realize how much fentanyl? We're talking about 57,000 deaths in 2020, up to almost 72,000 deaths that directly related to synthetic fentanyl. Now, a lot of people kind of are like, I don't really get it. Why is this fentanyl such a big deal? And the problem is it's being laced in lots of different things. So it's being laced in cocaine. So people that may not have a cocaine use disorder, but maybe use cocaine twice a year, may have a laced fentanyl and then they overdose. So this is a big problem. And fentanyl is made by pretty cheap materials, and it's not an agricultural product like heroin is, okay? So heroin has to be grown in an area. We know where it's grown. It needs to be transported from where it's grown to us, right? So we have an idea. When we talk about fentanyl, we're talking about really cheap things to make fentanyl, okay? So that makes it much harder, but also much cheaper, because an agricultural product is dependent on things like rain and sunshine and all of those things, where fentanyl is not. So this really is a very hard thing for us to combat. And we can see that it is, right? Because we can see the deaths escalating, and no matter what we're doing, it doesn't seem to be helping. Now, we know the interventions that have taken place since 2016, right? So the CDC guidelines came out in 2016 for opioid prescribing for chronic pain, non-cancer pain, and they even redid them in 2022. We have the prescription monitoring program that is required by all clinicians to be registered for and to look at before prescribing Schedule II opioids or other narcotic medication. We decreased the education requirements for ED physicians in particular, and then said you didn't need to have them if you had less than 30 patients. And then in January, right, that got rid of the X waiver altogether. We have mandatory opioid education in the state of Illinois, as do many other states. We require 3 hours per certification period. And now the DEA also is requiring a one-time attestation stating that we have done 8 hours of training. So all of these interventions have really taken place since 2016. Some of them more recently, some of them from before. Now, what has happened with all those changes, right? So we did all these things. What has changed? Nothing, right? The only thing that really happened is things got a lot worse. From 2016, again, 42,000 deaths. Now we're going to fast forward to 2021 and we're talking 80,000 opioid-related deaths. That is a 92% increase. Okay, wrap your head around that all of these interventions, all the things that we have done, nothing has happened. In fact, things have only gotten worse. And yes, of course, COVID-19 pandemic definitely was a catalyst, right? Because we know joblessness, insecurity, anxiety, depression are all drivers of substance use disorder. So what it also means is really important, and for everybody listening on this call, is the solution lies within us, doctors, APCs, not within the laws, because the laws haven't helped, right? We've only seen things get worse. So we really need to take ownership of this. Now, many of us contributed to the opioid epidemic unknowingly, right? We prescribed opioids. I've been practicing pain management for many years, for like 15 years. So, we used to practice, just give a little extra because you don't want them calling and you don't want to have to go to the ER. And we just didn't think that if we treated pain properly, that this would happen, right? We did not understand it. So we kind of were part of the problem. And now really the answer is going to lie within us now. Okay. Now the X waiver, this very specialized thing that put an X number in front of your DEA, which was required to prescribe buprenorphine. And the reason why it was required is because of an over century-old law from the Harrison Act that basically said that it was illegal for doctors to treat patients with opioid use disorder with an opioid. So this was when we thought that opioid use disorder was a choice, when we thought substance use disorder was a choice. And this all stems from when soldiers came back from the war and they were addicted to morphine. And doctors opened morphine clinics. The government felt that this was not an okay thing to do and made it illegal for you to do that. So the Data Waiver 2000 was basically a rule that made it okay that we wouldn't get prosecuted as physicians for prescribing buprenorphine for the treatment of opioid use disorder. What you may not realize is that you actually still could prescribe buprenorphine for pain. You only couldn't prescribe it for opioid use disorder without the X waiver. Again, this is a century-old law, act, right? Really long time ago. So that's what the Data Waiver 2000 was for. And so you can imagine now that we have such a wonderful understanding of addiction and substance use disorder, that it's a brain disease. We don't need that. We know how to treat this. We know what works, right? We don't need that X waiver. We need more people to understand this and not be afraid of this. So the X waiver is officially dead. As of January 2023, the X waiver is no longer required to prescribe buprenorphine. So this is really exciting, but we're going to see a little bit later on that, people are kind of scared of it now because you had to have this special license. And so everybody thinks it's a much more dangerous medication than it really is. So let's talk a little bit about the buprenorphine basics. And I will tell you guys, I do talk fast. I am trying to slow it down. So if you have questions, please put them in the chat and we will answer them. But what is buprenorphine? What is this magic drug? Well, it is a partial mu agonist and an antagonist to the kappa receptor. And what it does is it reduces cravings, reduces withdrawal symptoms, and reduces opioid and all-cause mortality. I'm going to say that again. It not only reduces opioid mortality, so risk for opioid overdose, but it also decreases all-cause mortality by 50%. How many drugs out there do we know that can do something like this? This is pretty impressive. And patients can be maintained on buprenorphine indefinitely. Again, this is what we're learning as we learn about substance use disorder, as we learn about opioid use disorder, is that these medications can be maintained. Patient can be on it forever. So what is Suboxone, right? So we talk a lot and we use these terms pretty interchangeably. Buprenorphine, Suboxone, right? They're one and the same. They're not totally one and the same, But what Suboxone is, it's a combination product, okay? So it's buprenorphine with naloxone, okay? Now, the reason why you do this is it's actually an abuse deterrent formulation. When you take this product orally, the naloxone has no effect on the body, okay? When it's taken orally, like the way it's supposed to, it has no effect. But if a patient was to try to inject this medication or snort this medication, the naloxone kicks in, okay? So that makes that drug inert, essentially. You won't get the high from it. So it is an abuse deterrent. Now, a lot of times people think that if you do an induction with Suboxone, you are more likely to get precipitated withdrawal than if you do it with buprenorphine. That is not true, okay? Again, if you take the product as it's intended orally, the naloxone doesn't do anything, okay? It does not cause precip withdrawal. It is simply an abuse deterrent formulation. So Suboxone or buprenorphine with naloxone are the commonly prescribed for home use, okay? Where buprenorphine, which is less expensive without the naloxone, is more likely used in the ER or in the hospital for an induction where we are giving the medication to the patient. So what is precipitated withdrawal, right? So we just kind of mentioned it. So buprenorphine has a much higher affinity, so a much higher stickiness to the mu receptors than opioids do. So when buprenorphine comes in, it kicks off all the other opioids. And when it does so, it puts the patient in acute withdrawal. That's what precipitated withdrawal is. And they don't feel well. So this would only occur in somebody who is opioid dependent. Again, acute withdrawal is not fun for anyone. Nobody really wants that to happen. So we try to avoid it if we can, but that's what precip withdrawal is. Now, again, a lot of people may think, sorry, next slide, that the naloxone, again, in the Suboxone is the issue. It is not. And the treatment for precipitated withdrawal is actually kind of simple, okay? Even though people get really, really worried about precip withdrawal, like, oh, what happens if we have it? You can push through it. And what that means when you push through precip withdrawal is that you give more buprenorphine to occupy more of the receptors, okay, to decrease the withdrawal. Because remember, buprenorphine is a treatment for withdrawal symptoms, okay? The problem with precip is that it kicks them all off and it's not occupying enough of those receptors to not cause the withdrawal. So the way you go around that is just by giving more buprenorphine. So it's very easy to do. And one of the ways you can avoid this happening is ensuring that your patient is in withdrawal before starting a buprenorphine product. And the way we do this is by a clinical opioid withdrawal scale, or a COW scale. In that COW scale, we want to be greater than 8 when we start buprenorphine, or greater than or equal to 4 if the person already had a naloxone reversal. So people may think they're allergic. So you might hear somebody in the ER or in the hospital or in the clinic say, I do not want Suboxone. I am definitely allergic to it. And if you ask them what happened and what their allergy was, they're going to tell you, I got so sick. I had headaches. I was puking. I felt awful. That's not really the allergy. Most of the time, that's precip withdrawal. Okay. And we want to educate our patients on that and reassure them that we're going to wait until you're in a good amount of withdrawal. Then we're going to start this and you're going to feel better. But it's very uncomfortable for a patient. And if you have never been through withdrawal, with most of us have not, it's hard for us to kind of relate to that, but it feels really awful. It feels like the worst flu of your life times 10. That is the way it's described to us. So all patients in any study who has an opioid use disorder, or even a substance use disorder, since fentanyl is being laced with many, many things, it is important to give naloxone. Bottom line is naloxone saves lives, and nobody can choose recovery if they are dead. Just not possible. Doesn't work that way, right? So naloxone should be part of the standard of care of every patient you touch with an opioid use disorder, or even a substance use disorder. If it's cocaine, cocaine's being laced. We want to make sure benzos are being laced with fentanyl. So it's really important. Naloxone saves lives. We are very lucky in the state of Illinois to have access to free naloxone at all of our hospitals that we can register for as a DOP. We'll talk about that more in the next webinar, but it is very important because Again, you cannot choose recovery if you are dead. Now, the highest rate for a fatal overdose is after a non-fatal overdose. So that's really important to keep in mind. Okay, that's really important to keep in mind that that is the highest risk. So when that person leaves your ER, leaves your hospital, they are at the highest risk for dying. The highest risk for dying. And very simple, we can give them naloxone. Very simple, we can offer them a chance of recovery, right? We can definitely save a life here. And a myth, and it's not really a myth, but in the old training, the ex-waiver training from way back when, really did not support the use of a buprenorphine induction after a naloxone reversal. We now know that you absolutely can do a buprenorphine induction after a naloxone reversal, and you could and you should, and that is not a contraindication. So if you've heard that, I want to kind of reassure you that that is no longer true. Lots of our ERs have trialed this in California Bridge, and everybody, we've done this where we have done the induction after a naloxone reversal with very good success. So please keep that in mind. Now, when we look at what California Bridge is a wonderful, wonderful organization in California that kind of really rallied around this opioid epidemic and has done great work and great research that we can all look to. But they looked between May 9, 2019 to June 2020, and they identified 12,000 patients in the ED that had opioid use disorder. It basically asked who wanted recovery. Now, a lot of people will think in the ED, well, they came in, they're just a junkie, right? We hate that word, just so you guys know, but we're just a junkie, right? They don't want to get better. They're in here all the time. You know, they don't want this, right? That's the theory. But nobody asked them. Nobody asked them what they want. Nobody asked them if they still want to do this, right? Because if you do, what California Bridge found out was 59% of the patients did want recovery. 59% wanted recovery. So we have to ask. We cannot assume that we know how this person is feeling. We cannot assume that. We need to ask that questions. And people may think, oh, well, if I do buprenorphine, it's going to increase our length of stay. And we all know all EDs are dinged on length of stay, right? But actually, studies actually show that it decreases length of stay, which is pretty cool. If you think about it. You know, again, when we think about opioid use disorder or substance use disorder, what we don't realize or we may forget is that after continuous exposures to opioids over a long period of time, that people that develop opioid use disorder are no longer using these substances to get high in many times. Most of the time, they are using the substances so they are not sick. Okay, because their bodies are so dependent on these medications that if they don't take them, then they have withdrawal and they cannot function. They are very sick. It's called dope sick. They don't feel well, right? So they are using to survive. They are not using for a good time. They're using to survive. And we do have a video at this point that I'd like to share.
Call, and I had the drugs out of my system for like a week then, so I was really miserable. I mean, vomiting and diarrhea and just shaky crawling out of my skin, and I wanted to use so bad, but I didn't want to use. And I called and I was able to speak with a doctor right away that day. I don't know if Dr. C remembers, but I remember talking to him, and he's like, it's going to be okay. I'm going to call and get you some medication. And I was like, today, now, like, I just like sobbed. Like I felt that I might be okay, you know? And I was so used to, you know, sign a list and then 3 months from today, you know, call every week and see if you can get in, that kind of thing. And to immediately be able to get help was just, I was dumbfounded. And it really gave me hope.
In our next video.
My
I mean, we all do some bad things
Yeah.
when we need drugs, but it's more of a function of utility than anything else. You know,
Yeah.
we'd rather not be stealing and hurting people. You know.
Yeah.
So these two patients, it's really, really interesting, right? You heard that, my son, right? My son told me how great this is, right? So this is really important to understand that how much we can make a difference here. And that, again, our gentleman there, I don't want to do bad things. It's a function of how am I going to live, right? She was saying how sick she was and how she couldn't function, and all she wanted to do was use, because she knew if she used, she would feel better, right? So that just tells you that this cycle continues, right? This is how we are conditioned. And if you know that if I take this, I'm going to feel better, you're going to do it, especially if you need to work or you need to take care of your kids, you're going to do it. Now, if we look here, so now we're going to talk again more about this a little bit more in the next webinar, but there is a code that is out that gets a higher payout. So usually in the ER, you don't get add-on codes, right? So not only is it the right thing to do, but it is the thing that will get the hospital and the clinicians that are doing this paid. It's really important to understand that, we're trying to do it from both ends, right? It is the right thing to do. And very many times the right thing to do doesn't get you paid. But in this instance, doing the right thing does get you paid. So this is the code, the add-on code to the ED visit that would get you additional monies, additional RVUs for doing an induction. And again, we're going to go through this in the next webinar on the logistics of how to do this, how to do a dot phrase so you can record all the good stuff that you need to record in order to get that add-on code paid for. So buprenorphine, I like to say it really is as easy as 1, 2, 3. Number one, patients wants recovery. How do you know that? You ask them. Okay, you ask them. And if they failed this before and they've come to your ER before and they've gotten Suboxone before and they come back, you still ask them, because we don't know what time will stick. Okay, we know it takes many times sometimes for it to stick. So you ask them. You do the induction with buprenorphine and you link them to care. It's as easy as 1, 2, 3. So again, step 1, patient wants recovery. Step 2, are they in withdrawal? Why are we asking if they're in withdrawal? Because again, we want to avoid precipitated withdrawal. So we want that COW score, the clinical opioid withdrawal score or scale, to be greater than 8, or 4 or more if they've had an naloxone reversal before inducting. And how do you do the induction? It's very simple. You give 8 milligrams. You give 1 full film of 8 milligrams sublingually. It's not IV, just sublingually, and you wait an hour. It's okay to start with a lower dose. So if somebody is dependent or using oral opioids, couldn't think of the word, oral opioids, as not an intravenous drug user, and you want to try at 4 milligrams, you can try at 4 milligrams. If they do use intravenous drugs, if they use heroin, if that is their drug of choice, starting with 8 milligrams is probably a more appropriate dose. So you start with 8 milligrams, you wait an hour and you see how they feel. Are their symptoms controlled? If they're controlled at 8 milligrams, guess what? We're done. That's it. We're done. You give them a prescription for 3 to 7 days. You give them that linkage to care, and you give them a free Narcan kit if available at your site. And again, next webinar, we're going to talk more about free Narcan. If they are not okay, if their symptoms are still strong, right, you're going to give another 8 milligrams and you're going to observe for an hour. Now, the maximum dosing for buprenorphine is 24 to 32 milligrams in a 24-hour period. Okay, so you have a little bit of wiggle room there. Now, once you go to the high dosages, you do want to do what we would call split dosing or twice-a-day dosing, because when a person takes Suboxone or buprenorphine, you never want to do more than 2 films at a time. Okay, so that's the most that a patient can have dissolve in their mouth at one time is 2 films or 2 pills. Okay, so this is very easy. Again, symptoms not controlled, you give another 8. You give another 8 and you wait. That's it. Okay, if they need more, you do split dosing. Again, really, really simple to do. And honestly, the patients are going to be grateful. They are going to be happy because they're going to feel better. Then you prescribe the buprenorphine. You give them the 3 to 7 days. Again, no X waiver needed, right? So all you got to do is prescribe it, and then you linkage to care, right? So that's the important part, is making sure that they have follow-up. And MAR now is the easiest way for us to do that. MAR now is available to us. Again, we're a pretty awesome state that we have this, but basically they call that number and they're going to care within 24 hours anyways. So there's a lot of fun stuff that we have in the state of Illinois that we just need to tap into. And again, prescribe naloxone. I'm going to say that 1,000 times because it's so important, because again, you cannot have recovery if you're dead. So make sure your patients have naloxone. And we're going to do one more video here. Samantha's going to share.
If you're going to do it just, cold turkey, it's a very long, lengthy process, weeks upon weeks. But the first time that I was given Suboxone, I couldn't believe it. I felt that same normal feeling, that same relief, as if I had just done, something else, but I didn't feel tired and I was like coherent. I was with it and I, had a clear mind. And so the first time I took it, honestly, I thought to myself, wow, this is like, I can do this and it's legal and I can do this every day and I can feel normal. And it wasn't necessarily the right mindset, but it was just like, it did like save my life. It saved me from who knows what could have happened next.
Wonderful. All right. So again, this whole X waiver thing made everybody feel like this is one scary drug, right? We have to be really, really nervous about this. It have to be super careful because you needed to have a very special DEA just to be able to prescribe it. So it must be dangerous, right? I didn't need to do an extra 8 hours of training to do Norco. So this must be very different, right? Rightfully so. We all thought that. And a lot of people don't realize what the reason for the data waiver was for it to begin with. But I want to draw your attention to this slide. So this is super interesting, okay? What it really is showing you that is that buprenorphine is really safe. So if you look at this orangey line here, you can see this linear, right? You can see that this plateaus well above respiratory depression. These are your traditional opioids. So if any time in your lifetime, if you're a APC or doc on this call, ever have prescribed Norco, oxycodone, fentanyl patches, any of the codeine, any of those things, what you can see is that all traditional opioids, this is the effect, okay? They plateau well above respiratory depression. But if you look at bup, right? Look at this. Look at how this goes up. This plateaus well below respiratory depression, which means it is really, really safe. It is actually a very safe medication. Not only can it be used to treat opioid use disorder, but because it is an agonist to the mu receptors, just like a traditional opioid is, it actually does treat pain. Okay, so that's a nice little kind of bonus thing that you have here. So this is a very safe drug. Buprenorphine is extraordinarily safe. And I want you guys to see this, understand this, share this, let people know. The X waiver had nothing to do with the safety of buprenorphine. It had to do with a century-old act and not because it wasn't safe. Now, why haven't we embraced buprenorphine, right? So if it's so great, why are we having all these discussions? Like, what is the problem here, right? And some of it's really just knowledge base, right? The X waiver went away January of this year. So a lot of people maybe not even realize that it's gone. They don't feel educated on how to utilize this because, again, in most of our residencies, so if you've been out of residency for a hot second, this was not something that you trained in. This was not something that was part of your pharmacopoeia. It just wasn't something that you saw. There's a lot of concern about follow-up, probably more so with opioid use disorder than any other condition that you see within the ED. There's some concerns for precipitated withdrawal that they don't want the hassle of, if I give this and they get sick and I don't really know what to do with that and how do I treat that? And then of course there is stigma, okay? There is unconscious bias. The words junkie, addict, dirty, war on drugs, right? Even the war on drugs, and I have a slide on this a little bit later, but I just want you to say that word out loud and then think about the images that come in your brain, right? It's us against them. They're the bad people, right? It just gives you this feeling, right? The war on drugs. It's really important because words do matter. They matter a lot. And I want to kind of let you kind of think about this, noodle on this a little bit. If you saw a non-compliant diabetic come through your doors in need of insulin therapy and a foot amputation, what would you do? Would you refuse to give them insulin? Well, because it was his choice, right? He ate the sugar. Would you refuse to amputate his foot? Because really, he's just going to need the other one taken off eventually, so why bother? Would you refuse to help him? Because you're really only enabling him. You're not helping him at all. This is tough love, right? We got to do tough love for this patient. Or do you only treat him if he promises to go to his follow-up appointment and to never touch sugar again? Because if he can't make those promises, you're not giving him the insulin. And if any of those things sound ridiculous to you, now just switch those words around a little bit, okay? Non-compliance is not something new to the ED or to medicine in general. This is something we deal with all the time. So it's important that you switch those names around a little bit and see how you react a little bit differently, because it kind of uncovers what we grew up with and how we were taught to think about substance use disorders, even though we know that it's not a choice. So we talked a lot about bupe, right? But wait, there's a whole other drug, right? There's methadone. So what about methadone, right? What's the difference? What's going on with methadone? So methadone's interesting, right? So methadone is a full opioid agonist, okay? So there's no antagonist part of this, okay? You do not have to be in withdrawal to start the medication, okay? So that's kind of a nice little bonus. You do need to take it every day, okay? You need to take the buprenorphine every day too. But the problem or the difficultness with methadone, okay, again, you won't get precipitated withdrawal. You don't have to wait for a patient to be in withdrawal. But these are some of the things that are kind of hard about it. It has to be dispensed by a federally licensed facility, and you need to go every day. And you need to be watched to take the medicine every day. And you can't start if the patient is already on over 40 milligrams, the federally licensed facility can't take the patient. So you have to kind of start over again. Okay. So if a patient lapses, they have to start over. So if they're on 120 milligrams a day, they have to start at the beginning dosages and then titrate on. So there's a lot of little kind of things, intricacies to methadone that you may not realize. And I also want you to kind of think about what it would feel like to have to be witnessed during your recovery. Every day, you have to go in and kind of drink this medicine in front of somebody every single day. So that's a hard thing to do. So you really have to be pretty dang motivated to be able to do methadone. Now, it does decrease your risk of overdose. Absolutely, it does. But you do have a higher risk of overdose if the patient combines methadone with another opioid or another sedative medication, including alcohol. So, it's not, again, overall, does it decrease opioid use disorder or opioid overdose? Yes, but if it's combined with another opioid, a benzodiazepine, or another depressant, then you have an increased risk of death. And again, it does require a high commitment from the patient. And a lot of times this is looked at as liquid handcuffs, because again, you got to go there every day. You got to be witnessed. And when you're good, you get one day home, right? You get Sunday, right? You go there 6 days a week, you get one to take home, and that's it. So it's really, really hard. And I believe we have another video here that Sam's going to share.
First of all, there were people. First of all, there were people, and we're not bad. We just made bad choices. And I think that's real important. It's important that people don't look down on you. You feel bad enough already. And when somebody, it might be a tone of voice or something, they say, maybe I'm overly sensitive, but I don't think so. But they should know that we're people and we have all kind of talents and stuff. We're not just junkies. There's more to us than our addiction.
And I think that's such an important thing, right? If we were all judged on our worst days, the worst thing that we've done, how would we be judged, right? Like, how would we look? It's really important to kind of think about that. When a person comes to the ED in this state, they're at their most vulnerable. They don't need judgment. They need help. They need compassion. They need somebody to look at them and say, yeah, hey, do you need help? Do you want recovery? They don't need the judgment, right? So I love that video. I love the way she says that, we're not bad people. We may have made bad choices, and that we're more than just our, opioid use disorder, which is really important to understand. And I love this quote, and we put it in here. Prejudice is a burden that confuses the past, threatens the future, and renders the present inaccessible. And I think that's a lovely quote. And I think it's important that we understand that stigma plays such a huge role in the treatment or lack thereof treatment of opioid use disorder. People of color receive more methadone than buprenorphine, and white people receive more buprenorphine. Overall, Black patients are less likely than white patients to be offered any type of medication-assisted treatment or medication recovery. So whether that be methadone or buprenorphine. And stigma towards opioid use disorder really intersects with racism, resulting in a reduced access to care. We should be asking all patients, regardless of race, whether or not they are choosing recovery if they have an opioid use disorder. And we should also be offering them options that they choose from. That is a really important thing for us to be able to do. Now, we talked a little bit about this, and I kind of mentioned that term, the war on drugs. This is very racist. And it came out in the 80s. We all grew up, a lot of us grew up with it. And a lot of our unconscious bias comes from this, of the images we saw growing up. And then again, it was us against them. Okay. And this was a really not a great thing here. And this was the infamous 100-to-1 ratio between crack and powder cocaine sentences. This basically made it so that the prisons were flooded. Right. And people were getting lengthy prison sentences for this, like ridiculous, like life sentences for something like this. And even the Supreme Court in 1991, the decision basically said that mandatory life imprisonment sentences for first time drug offense was not cruel and unusual punishment. Okay. First time offense for drugs, lifetime prison. Do those things equal too much to anybody listening to this? That seems weird. And think about prison sentences for things like child molestation or rape or any other a murder, all of these things, right? But for one first-time drug offense, the Supreme Court in 1991 said this was not cruel and unusual punishment. In 2012, there was a ruling, Miller versus Alabama. Now, this held that mandatory life sentences without parole basically violated the 8th Amendment's prohibition against cruel and unusual punishment. So it took to 2012 before somebody said, you know what, that doesn't seem right. That seems like that's a wrong thing to do. That is cruel and unusual punishment. But look how long it took for that to occur. Now, the war on drugs resulted in Black people being disproportionately arrested, convicted, and imprisoned for possession and distribution of crack cocaine. So to understand what this meant was that 5 grams of crack cocaine, which is a couple packets of sugar, okay, just picture a couple package of sugar, was equivalent to 500 grams of powdered cocaine. Okay, both of them resulted in 5 years prison sentence. In 2010, the Fair Sentencing Act, which reduced the disparity between crack and powder cocaine. Again, 1986, 2010. Okay, these things are not turned over quickly. So this all leads to our unconscious bias. Now let's talk about women. Okay, so now we talked a little bit about that. Now women are really getting the short end of the stick here. So women are prescribed more opioid pain medication than men. And while men are more likely to have used IV drugs in the past 30 days, women are more likely to misuse prescription opioids. Women actually experience more chronic pain than men do, and women are prescribed at a higher dose than men, even though women become dependent at a faster rate than men do when it comes to opioid pain medication. And it has to do with body mass, smaller frames, fat distribution. We also know that women also have their adverse childhood events play a higher role in the development of substance use disorder as well. So women with children have even greater challenges in seeking help for opioid use disorder because of the fear of losing their children and because they will lose their children, right? We punish women who come forward and say they need help. We call DCFS. Their children are taken away. So this is not a, not a real threat to these women. This is a true threat that if they want to get help, they have a risk here. So women that are treated with opioid use disorder should be screened routinely for pregnancy. And if they're not pregnant, they should be offered contraceptives. And many of the patients, women specifically, who have an opioid use disorder have had significant traumas in their life. Very much so, their adverse childhood events are highly related to substance use disorder. And women aged 45 to 54 are more likely to die from an opioid overdose compared to other age groups. Was that the age group you thought about when you think about it? Probably not, right? 45 to 54, that is going to be your highest risk for a woman. And in 2018, 4.5 million American women suffered from opioid use disorder. That is 3.5% of the female population in the United States of America. 3.5%, right? So it is no surprise that we see an increase in neonatal abstinence syndrome. And in 2018, it was said that a baby was diagnosed with neonatal abstinence syndrome every 19 minutes, or nearly 80 newborns diagnosed every year. So not only are these children, these little tiny babies, suffering, their lengths of stay go up, and obviously the cost is very expensive as well to the United States, right? To us. Opioid overdoses account for 10% of pregnancy-associated deaths in America. 10%. That's a lot of deaths. That is a lot if you think about it. 10% of the pregnancy-associated deaths are related to opioids. And 80% of the women who've died of an opioid overdose had contact with a healthcare provider. So we had an opportunity to intervene and we didn't intervene. For women that actually are treated with methadone or buprenorphine, the odds of an opioid overdose is 60% less. So again, we know this makes a huge difference. But at the same time, when we look in 2019, only 2% of the OB-GYNs were prescribing buprenorphine. So even though we know this is a treatment, even though we know this can make a huge difference in a patient and in the baby's life, only 2% were prescribing it. We know that a patient that is pregnant and dependent on opioids, abruptly stopping opioids during pregnancy can lead to preterm labor, fetal distress, and miscarriage. And really, concerns for neonatal abstinence syndrome should not prevent anybody from doing medication-assisted treatment. And of course, the preferred medication-assisted treatment isn't a full opioid agonist. MAT or MOUD, so the treatment, buprenorphine, methadone, really should not be stopped in patients until they're through their postpartum period, when their babies start sleeping through the night, because that is a very high risk for relapse during that time. So why is this more important than ever? We worry about fentanyl, right? But why is this more important than ever? And it is because there's a new adulterant, okay? There's a new adulterant out there, and I'm sorry that I don't think the pictures came through. I'm not sure if the pictures came through with this, but there's a new drug. It's called xylazine. It is trank dope, or zombie. And it is an animal tranquilizer that is not meant for humans, never been tested on humans, not for humans, right? It works much like clonidine, okay? So it's an alpha-2 agonist. It is, again, never been tested in humans. There's no human reversal. There is an animal reversal, which is an alpha-2 antagonist, but this has never been tried in humans before, so you really can't use it. And it can cause seizures. And interestingly enough, this medicine that is used to tranquilize animals is not supposed to be meant for any food products that we consume. So this is really not meant for humans at all, but it is made its way into the drug market. It started on the East and it's coming this way. And we definitely see it in Chicago now. And it's very scary because just like fentanyl, you can't see it, you can't taste it, you don't know what's in there. So it's a very scary thing. And the effects can be very quick, okay? They turn on really quick. and they can last 4 hours. They're usually mixed with another illicit, usually fentanyl, but it's usually mixed up in there. And patients develop these very deep necrotic wounds. And again, I'm sorry that the pictures did not come through, but it's important they are deep. I mean, they're to the bone, very huge ulcers. So if you have patients that come in with ginormous ulcers on their extremities, this is something you have to think about, especially if you know they are an intravenous drug user. You have to be concerned about this. And it's not that it comes at the site of injection. It can be anywhere in the limbs. So it's not in a site of injection. So don't think that that's where it needs to be, because that's not where it needs to be. And people have needed to have amputations. It causes vasoconstriction in the limbs, again, because again, remember, this is an alpha-2 agonist, right? So it causes this vasoconstriction, so there's no blood flow, which is what causes these big necrotic ulcers. Naloxone is still going to be important here. Now, you're not going to see the traditional, oh, I gave naloxone, they woke up, so therefore it was an opioid overdose. You know, that's not what's going to happen if it's contaminated with xylazine. You won't see them wake up that way. They're not going to pop up, okay? Their breathing may get better. Because again, you're reversing the opioid-induced respiratory depression of this, right? You're reversing that part of it, but they may not wake up, again, because this is a sedative. And we don't see this in urine drug screenings yet. You know, it took us forever to get fentanyl in routine point-of-care urine drug screenings in the ED, and a lot of us still don't have it. Xylazine, God knows when that's going to come through. So you're not going to see it. So if you give Narcan and they don't immediately wake up, does not mean it's not part of an opioid overdose, okay? If their breathing improves, it's likely still an opioid overdose, but it's likely contaminated with xylazine. And again, in Chicago, this is definitely happening. So these are our patients. And I think we have one more video, right, Sam?
Yes.
Can you do that for me?
Just made bad choice.
Just to be patient, treat them like a human, you know, understand where that they're coming from. Sorry, I didn't think I was going to get this emotional. You know, for these patients that keep coming in and out, or even for the first time, and you don't ever see them again, or they don't want to keep using. They don't want to keep living like this, but this is the only way that they know. This is the only thing that they know how to keep doing, because it comes so routine in your natural habitat. And it's a hard cycle to break. But with that extra push and that compassion, they definitely can do it.
You know, and I think this is really, it's really important to understand that, right? It's really important to, you know, I think Crystal in that video says it best, you know, treat them with compassion, right? You know, understand this is not something they want to do. Each one of these faces on here are wonderful patients that are in recovery now. Each one of these faces represents somebody that you could help. These patients now are, you know, daughters and mothers and sisters and husbands and fathers, and they're now contributing to society because somebody gave them a chance. Somebody had compassion for them. Somebody offered them help. Somebody said, I care. And look at them. They're doing amazing. This represents, you know, each one of these people represents somebody that you could help as well. And we have this within us. And we have this within our power, especially now the X waiver is gone. It really is as easy as 1, 2, 3 to save a life. So in closing, of course, you guys want your CME, please obtain your CME. As you all know, that it is a requirement now that you have 8 hours of substance use disorder training in order to renew your DEA. So please scan, or is this the scan code for this? Or is this for next week, Sam?
This is the scan code. So you can either use the QR code right here, or Julie dropped it in the chat. The enrollment key for this webinar is actually webinar 3, no spaces. We'll drop that in the chat as well. So feel free to use that. It'll take you to a quick evaluation, and then you'll get your CME credit for this webinar.
Yes, and we have another webinar coming up about kind of really Marnell and how to get paid and all the fun stuff. So if you enjoyed this webinar, please register for webinar number 4 so that you can hear all about those wonderful details. And I'm not sure if there's any questions in the chat. I can't see them, to be honest.
We had a couple of questions come through. One of them is a little more detailed about the Medicaid billing code, G2213. Are there examples of dot phrases that hospitals are using to incorporate the expert with the new Medicaid billing code?
Absolutely. And in webinar number 4, we're going to be sharing some dot phrases with that and some updates on how to get reimbursed for that code and some changes that are coming up as well. But we do have dot phrases, and that will be in webinar number 4.
And another question that had come through at the registration, knowing that xylazine and fentanyl are big emergencies right now, what can we do in terms of quick prevention, like getting access to testing strips in the city? Do you have any resources?
Yeah, in Chicago, you can get access to free fentanyl testing strips, and they will, if your hospital is able to and willing to give them out, you can give them out as well. And it is, it is possible to do. We don't have testing strips, from my knowledge, for quick xylazine testing at this point, but we do have it for fentanyl testing. In the state of Illinois, city of Chicago, I should say specifically, city of Chicago does have access to those that they can, that you can have shipped to your hospital. You send out. You do have some tracking requirements on who they go out to, and we can get you that information offline as well.
Awesome. And then another question that had come in earlier, for treating people who come into the emergency department with chronic pain, but also have opioid use disorder, how do you support pain management?
So if somebody has an opioid use disorder and has chronic pain, buprenorphine can be used just as well. And buprenorphine is an opioid agonist. Now, if somebody has been on bup for a long period of time, just like any other opioid, so whether that be Norco, whether that be Oxy, whether it be any of those things, there's tolerance that occurs to the analgesic properties of any opioid. So you have to kind of anticipate that. So if you have somebody that comes in who's already on methadone and been on methadone for many years, or been on buprenorphine for many years, and then comes in and had a car accident, let's say, and broke a femur or had rib fractures, the idea that their controller medication would be enough to treat the acute pain is false. But that is also true for anybody who's on chronic opioids for pain as well. So if you have a patient that is on chronic opioids for pain and they come in with an acute injury, their controller medication, whatever that is, will not be enough to cover the acute pain that they sustained from that car accident. So you do have to add supplemental opioids to those patients. So it just depends on how much bup is their normal dosing. So if their normal dosing of bup is 8 to 12 milligrams a day, you can, if you need to add some supplemental opioids on while they're in the hospital, you can do that and get pain relief, because not all the receptors are covered at that point. And please let me know if that did not answer your question in the chat so I can be clearer. But we need to remember that buprenorphine is used to treat pain in chronic pain patients. Butrans is the buprenorphine patch. Belbuca is the buprenorphine oral disintegrating, or like the same thing as the sublingual that we give for opioid use disorder. So buprenorphine is used to treat chronic pain in pain patients. So it will treat pain in patients with opioid use disorder as well.
Wonderful. Thank you, Dr. Butari. I think that is all the questions that had been asked previously. if there are, I don't believe there's any other questions in the chat or the Q&A function.
And
Um,
Samantha, I just want to say one more thing about the pain. So
Yeah.
sorry, just because, that's kind of my home. But, with pain, we always have to remember that there's more than just opioids in pain management. And we have to think about all the things that, that can be pain controllers, from Tylenols to nonsteroidal anti-inflammatories to topicals to TENS units to acupuncture, which is now covered by Medicare. All these things that are out there, we really need to think outside the box, that sometimes pain control doesn't come in a pill formulation. Sometimes it's other things that we need to add on there, lifestyle changes and whatnot. So you can do a really, for a patient that has an opioid use disorder, you really can give proper pain care with or without an opioid.
Awesome, thanks so much. Is there anything else that you'd like to add, Dr. Bhattacharya, before we close out?
No, thank you guys for joining.
Thank you. And I think there's an additional slide after this.
Yes, ma'am, there is. There you go.
So this is the certificate of completion that you'll get upon receiving your CME credit by using the link in the chat. And then the next slide.
Sorry, there you go.
There you go. The next slide has our final webinar, which is Tuesday, July 25th, also being presented by Dr. Bhattacharya on successful collaboration, referral workflows, and payment. So we hope that you join us there as well, and you can find that on the website. And we appreciate you taking the time to be with us today. And thank you, Dr. Bhattacharya, and all of our subject matter experts.
Thank you, everyone, for coming. Really appreciate the participation and the opportunity to share this information. Thank you.